A very good morning to one and all. Welcome to the day 5 of the GAN course. We'll be starting the session now. I request Dr. Hitesh Handa to please start the presentation.
Okay, guys, good morning. So I hope you remember, day before yesterday, we talked about protein surface interactions. Proteins adhere to the surface. Yesterday, we talked a little bit about platelet activation and how platelets get stuck to the surface, right? So today, we are going to talk about a huge problem, and that's infection. For most medical implants, infection can be very challenging, right? So let's start. Again, protein adsorption is still there, but once protein adsorb on the surface, it's creating a nice environment for bacteria to get stuck on that surface. And now bacteria can adhere to it, multiply on it, make biofilms, and that's what we are going to talk about today. Okay. Now, this information is a little bit old, 10, 15 years old, but I'm sure the new numbers are very similar. So, in US alone, 1.7 million infections per year and 100,000, that causes 100,000 deaths, right? Now, I think I was talking with some of you earlier that I don't know how accurate these numbers are. Maybe the real numbers are even higher than these numbers. And you can imagine if these are the numbers in US, these numbers can be significantly higher in developing countries. You know, it can be because of poor hygiene, poor conditions in the hospital settings, lack of working with the devices carefully for nurses and doctors. So it can have all the different reasons for this healthcare associated infections. Another thing we will little bit talk about today is antimicrobial resistance. So once this antimicrobial resistance is there, now it becomes even more difficult to kill the bacteria because it has developed resistance towards antibiotics, right? So a little bit off topic, so I don't know if you guys remember, and maybe the show is still there, Satyamev Jayate, I think Amir Khan's show, right? I remember there was an episode in his show on tuberculosis. Okay, huge problem in India, and I don't remember, it was few years ago, but they discussed that how if somebody has tuberculosis, you need, let's say, approximately 6 months course of antibiotics. But after few days, weeks of medicine, people start feeling better and they stop taking antibiotics. But that's one reason how antimicrobial resistance gets developed. Now the bacteria that survived, now they are learning how to not die with that type of drug, right? So now they are becoming resistant to that antibiotic. Another thing that they showed in that show, I remember, was that how sometimes people are poor, they cannot afford the drugs, so they feel I'm fine, I don't need to take more drugs. Sometimes even when they can get the drugs from these free medicine clinics, either they don't have medicine or due to corruption, they are not giving the full dose to the patient and they are telling them, oh, we are out of medicine this month, come next month. Or you don't need to take the medicine every day, take every other day, you'll be fine. But these are the things that lead to antimicrobial or antibiotic resistance. And it just becomes a more bigger and bigger problem and out of control than to contain this situation. Now, infections, biofilm formation, it's fourth leading cause of death in US. I already said how many million of people get affected, how many deaths. usually common bacteria are Staph aureus, Pseudomonas, Staph epidermidis, Acetobacter baumannii, E. coli. These are some common culprits with medical devices associated infections. And of course, you can imagine it adds billions of dollars in hospital cost, right? Even the sad part is somebody is going to the hospital to get treatment for something else. They are getting treatment for, it can be anything, right? Like they can be on dialysis, they are dealing with that issue, or they are hospitalized for some implant. Maybe that real problem, or they are cancer patients, they are immune compromised. In addition to getting treatment for the original problem, their urinary catheter is getting infected, right? And you can imagine just one small infection, when we have throat infection and you have to take antibiotics for 5 days, how terrible we feel with that antibiotics. And now somebody has to keep taking it because their urinary catheters are getting infected, right? Or endotracheal tubes are getting infected, or vascular catheters, hip implants. These hip implants are even bigger issue, right? Because somebody's urinary catheter gets infected, you can remove it and put a new urinary catheter. Yes, it's a problem. Somebody needs to get a antibiotic treatment, but it's still not that big of an issue. But if somebody's hip implant gets infected, now that might lead to a new surgery now to get it removed and cleaned and put a new implant. So 60 to 65% related medical implants that get infected, endotracheal tubes, orthopedic implants, cardiovascular implants. And then I was trying to find some numbers for this morning only. So because of jet lag, I woke up at 3 o'clock, okay? So I was actually waiting to come here so that we can start the class, okay? So I was looking for some numbers from India, and I found this, and here is the Hindu link if you want to look into it. 5 bacteria types claimed approximately 7 lakh lives in India in 2019. So 7 lakhs. Okay, can you please open while we are, I'll keep going, but check the link. Was it 6.8 lakhs and I approximated to 7? Just check it one time. I don't want to say, give you wrong information. So you can imagine just those 5 bacteria, and I think bacteria are Staph aureus, Staph epidermidis, Pseudomonas, Acetobacter baumannii, and I forgot there is one more bacteria. These main 5 bacteria costing that many deaths in 2019 in India. We have internet here, right? I can 6.8, right? Yeah. So 7 lakhs is the correct number. Yeah. So, but you are right. It says 68 here, so that's a little misleading. Okay. So bacteria can be gram negative or gram positive. Now, you can find if it's a gram negative or gram positive bacteria. So, okay, before I go further, any of you work with bacteria? Infection, bacteria? No, right? Okay. That
worked earlier on Pneumonia itself.
Okay, great. So, you can stain a bacteria to find out it's gram negative or gram positive. Okay, so and it's based on this gram negative, gram positive on the person, Danish bacteriologist who developed this technique in 1800s. And what happens is gram positive has a thick cell wall, whereas gram negative has a thinner wall, maybe 10 times thinner, I guess, and they get stained different color. So it can be gram positive or gram negative. Now, some examples of gram-negative bacteria: E. coli, Pseudomonas, Acetobacter baumannii, gram-positive Staph aureus, Staph epidermidis. I'm talking more in terms of medical device infections little bit. Okay, there are a lot more bacteria, but I was just trying to focus on those particular. Now, can you guys think of few reasons why infection or contamination happens when somebody gets a medical device implanted or during implantation, what are some common reasons for infection to happen?
So infection at the surgical site.
Surgical site infection, yes.
It can be a late infection due to chronic inflammation.
Yes. And why surgical site infection can happen?
Due to the different instruments, not instruments, different equipments being used during the surgery. It may
Yeah.
sanitization or sterilization of the.
So if they are using the different instruments, if they are not properly sterile, that can cause infection. And remember, you are cutting open the skin, and now a bacteria can go inside and it can multiply. Unlike blood, platelets, red blood cells, bacteria can divide and multiply, right? Also, patient's own skin is a problem, right? We have bacteria on our skin. So when you're cutting it, your own skin can cause bacteria to go inside that site. If hospital staff is not careful, that can lead to infection also, right? So hands of medical staff, surgical equipment, patient's skin, contamination or insertion. So while implanting that device, that bacteria can get introduced. So hub contamination during usage. So for example, when somebody has a catheter implanted, let's say vascular catheter, there is a hub or the access point outside where they are using a syringe to draw blood or infuse medicine. If that hub every time is not cleaned properly, that can introduce infection in that device also, right? So source of bacteremia or infected blood, it can be through the gum disease, through catheter contamination, through implant. Any of these can lead to bacteremia. Now, bacteria can be free floating. We call it planktonic bacteria, or it can be attached to the surface in a biofilm. And we'll talk about biofilms soon. So a planktonic bacteria is like, let's say by itself, floating in blood. Once it's adhered and it's multiplying, now it's forming a colony or a biofilm where a lot of bacteria are growing together and making a environment for them to grow and thrive. 65% of human bacterial infections are biofilm related. So we will talk, when we'll talk about biofilm, but since biofilm name is coming here and most infections are because of biofilm, you can imagine when a bacteria is planktonic or free-flowing, floating, versus a group of bacteria in a biofilm, it's easier to kill that planktonic or free-floating bacteria. It's by itself, alone. Once they start making group, it will become difficult because they are united now. If you can search on Google Scholar, over the years, a lot of researchers are trying different methods to fight infection, and we will talk about antimicrobial surfaces probably early next week, but hydrophobic, hydrophilic, smooth surface, rough surface, lot of different surfaces have been tried, but almost bacteria likes to stick to sooner or later to almost everything. So bacteria can adhere to very hydrophobic and to very hydrophilic surfaces, can colonize very smooth or very rough surfaces. It can use flagella like a tail to move forward and swim, kind of. First few hours after surgery are more critical. So a lot of time, I think I mentioned last time that when my father had a surgery last year, they put a rod in his arm. So few days before the surgery, he was on antibiotics, and then few days after the surgery, he was still on the antibiotics, just so that that period is more critical. During surgery, if a bacteria was introduced, they wanted to make sure that that antibiotic will hopefully take care of that bacteria. And staph epidermidis, 60% of the prosthetic hip implants, that bacteria is responsible. So let's see how much you can imagine. If you have to work with bacteria, what do you think should the steps be? Like, let's say I give you some bacteria that, hey, here is staph aureus, grow it and then do the testing. What do you think how the growth of that bacteria is usually? Like, if we have a x-axis, y-axis, time versus concentration, how do you think the bacteria will grow?
Initially, the growth will be slow, but after some time, the growth will be exponential.
Yes.
And afterwards, if we didn't provide it proper nutrients, then suddenly the growth will decline.
Great. You said you didn't work with bacteria, but you know everything about bacteria. Yes. So, yeah, so that's correct. So, when we work with bacteria, first bacteria has a lag phase. So, it's kind of bacteria is getting used to the environment, you know, in that. So, you give good media to bacteria, that it's food for bacteria. So, bacteria is getting adjusted to it. It's growing very slowly. Then now it's like young time. They are very energetic and young time for bacteria for really multiply very fast and growing exponentially. But then you have limited food in that test tube, and now the death rate and growth rate becomes almost same. It's multiplying, but it's dying also. So now it's plateau or stationary phase, and now food is even reducing. So now the multiplication is slowing down, but death is going faster. So now that's the death phase. Approximately, so I was saying how bacteria can multiply, divide in 1 becomes 2, 2 becomes 4. How long do you think it takes for bacteria to multiply usually? It will depend on bacteria to bacteria, definitely. But approximately, what do you think for E. coli, I don't even know for all the bacteria, for E. coli, staph aureus, approximately how much time do you think it? See, you guys know everything. Yes. How did you know that? Okay, great. Yes. So E. coli, it's 17 minutes, staph aureus, it's 30 minutes. So approximately that time, it's doubling. Okay. Now we will do a numerical problem. So on the next slide, we will look at the formula, write it down so that now growth rate and generation time. So we start with 1 bacteria, it becomes 2, that's the first generation. 2 becomes 4, that's the second generation. 4 becomes 8, that's the third generation. So generation time, or capital G, is equal to time divided by number of generations. Capital B is the number of bacteria at the beginning of the time. You know, let's say I said there are 2 bacteria. Then small b is the number of bacteria at the end. So let's say it's 10. T is equal to time interval in hours or minutes. N is the number of generations. So the formula is small b is equal to capital B multiplied by 2 to the power n. We take log on both sides. So basically this is the number. Okay. But then on last slide we said generation time is equal to T divided by N, and N is this. So write it down because there will be a numerical problem on the next slide. So you can write the formula down so that you can solve it. And you know the exam that we will have, there might be a question like this. So you know you can take time in hours or minutes, but I'll recommend take it in minutes, because you just told me that multiplying time is around 20 minutes or something, right? So if the number is going to be like that, then you will get an answer in point something. So you just have to use this formula. You know t is 240 minutes. 3.3 multiplied by log 10 to the power 3, which becomes almost 10, 9.9. So 240 divided by 10, or 9.9 if you want to be very accurate, approximately 24 minutes, right? And if you want to talk about it, we can talk about it later. Okay, so next slide, our cell phones. So I had a PhD student, and for fun, one time we did this quick and dirty study. So what he did is he put some buffer on the cell phone and swabbed the cell phone and grew bacteria from it. Okay, and that's what I'm going to show you. So we will talk about how we work with bacteria later. So don't worry about how the experiment was done. I will talk about it in next 30 minutes, 1 hour. But I'll just show you. This was his cell phone. Okay. And that, so all this is bacteria. Okay. And we will talk about it, how we do it later. So this is all bacteria growing. And then he used alcohol, 70% alcohol, to clean the cell phone, and again did the same study. Just clean. So maybe we should periodically clean our cell phones. Okay. Okay. So let's talk about biofilms. Now, do you guys, I think you guys can guess what is a biofilm, right? So biofilm is lot of bacteria, aggregate of bacteria together, right? So bacteria can multiply every 20 minutes approximately. So when bacteria colonizes a surface or a medical device, let's say, it's multiplying, but at the same time, it's also forming this complex, heterogeneous, genetic, polymeric substance around it, like a gluey thing or a slimy thing on the surface, to protect the bacteria inside that slimy thing. You know, all this is biofilm. Okay. Now, biofilm is complex aggregation of microorganisms, and what's make it more complicated is biofilm is not just Staph aureus biofilm. It might have Pseudomonas in it also and Staph aureus also in it. So it might have multiple bacteria or fungi all together. That's why when somebody gets infection, if the bacteria is a planktonic bacteria, it's easy to take care of it. Once it starts forming a biofilm, it becomes more and more complicated to take care of it. I'm just seeing what I'm going to carry on videos. So dental plaques, sewage, live tissues, medical implants, they all can have these biofilms. You know, when there is like flowing water bodies and there is slippery rocks there, those are biofilms also. You know, bacteria is growing in it, and you can also imagine they all are not just growing, they are protected in that covering also. You know, usually they say a mature biofilms form in a week or two. Okay, and so bacteria will adhere to the medical device, it will start multiplying, it will start excreting this extra polymeric substance, EPS, that's that gluey thing around it, and now bacteria is multiplying inside that gluey thing in it. Let's see. It can be one or more species, can spread. So another thing that biofilm can do is bacteria is protected in it, but if there is a tiny hole or a piece of biofilm or that EPS gets removed, some bacteria can escape it and go and colonize a new place. Or if a piece of biofilm breaks, an embolism can happen, or even that piece breaks and it gets stuck somewhere else. Now it can start growing in the new spot. Yes, we talked a little bit about this. So recruitment, okay. This is approximately how it looks. You have bacteria adhering, slowly growing, mature biofilm forming, that biofilm is breaking, bacteria is going and starting a biofilm in a new spot. Now, factors that influence biofilm formation: pH, temperature, surface chemistry, hydrophobicity, nutrient availability. Another thing what biofilm does is, since it's this protective covering, antibiotics cannot penetrate it very easily. So now you need 500 times, 1000 times higher dose of antibiotics to take care of bacteria that's now protected inside a biofilm. Okay. Can you guess approximately, it's coming, but approximately in a biofilm, how much is bacteria and how much is this extra polymeric substance protecting it? What's the ratio? Okay, so bacteria has this pili that's like these things that can help adhering to the surface, you know, and once first the adhesion is very weak, but van der Waals forces or something, but once it adheres, now it can grow and now the adhesion can become stronger and stronger. Kind of like how we were talking about proteins, or little bit like platelets. Initially they attach, then they get activated, then they become strongly adhered. So same thing is happening here. If these initial attachments are not broken, they anchor much more strongly to the surface. And now they are just growing happily. Again, just showing that steps in biofilm formation, bacteria adhering, like this is a titanium material, adhering, aggregating, multiple bacteria are aggregating together. Now you can imagine you might need multiple antibiotics because you don't just have one bacteria, you have multiple bacteria in that. And to make things worse, there can be drug resistant bacteria involved now, right? Or if somebody does not finish their antibiotic course, they might develop drug resistance. Okay, mushroom shaped clumps of bacteria. These have extracellular polymeric substance or EPS protecting it. We little bit talked. Slime, it has DNA, proteins, polysaccharides, all in that biofilm. And EPS is secreted within 30 minutes of binding to the surface. So bacteria just start working very fast. To answer that question, 40, 60, 50, 50, so it's 10, 90. So it's only 10% bacteria and 90% of that slimy thing protecting that bacteria. Okay, so it's like so much protection is given to that little bit bacteria so that you cannot kill it. And this bacteria, it's resistant to dehydration, metal toxicity, UV light. They become a little bit dormant. They are just surviving in very minimum conditions, but they are not dead. And now you are giving antibiotics, it's not penetrating. You are trying to shine UV light, this is protecting it and bacteria is not dying. So it just becomes very difficult to take care of infection. The problem is, I'm not a clinician, so I'm not a doctor, but knowing all this is very scary actually, because you know how bad the infections can be, right? You know, ignorance is bliss. Not knowing is, I think, better than knowing this, that, okay, all this can happen. Another thing is, bacteria can talk with each other, and they call it quorum sensing. Okay, so there can be channels for them to communicate with each other. Bacteria can release chemicals that are absorbed by other bacteria, and they are just talking and interacting with each other. So, you know, what if you are giving some drug to kill bacteria? This bacteria is talking with more bacteria, and it's informing the bacteria that, hey, something is coming to kill you, start protecting yourself. So now they can close their pores or become more dormant. So if something is coming, they won't even absorb it. Their gates are closed now. So now bacteria is not dying. First of all, anyways, you had to give 1,000 times the dose of antibiotic. Now bacteria is prepared to fight you. Now they are not even taking that much. Some bacteria escape, colonize, we little bit talked about it. So we cannot watch videos for online reason, but here is a link to this video. It's a nice video, you guys can watch it later. Just talking about how biofilms form and what happens when they detach and release. Okay. We already talked about this also. They resist antimicrobial agents. See, another thing with antimicrobial agents is, when you have an antibiotic, you know that you are killing gut bacteria also, right? Like so remember, when you give very high doses of antibiotics, yes, it might be taking care of biofilms, but it might be very toxic to your body also. So it's easy to say that you can give 1,000 times the dose of antibiotic, but what adverse effects are going to happen now, you can imagine, right? And if it's an implant, how do you even clean that biofilm now? You might have to do a revision surgery to remove it and put a new implant. Now, they say these escape pathogens are the most common pathogens responsible for infections, hospital-acquired infections. Okay, Staph aureus, Acetobacter baumannii, Pseudomonas, they have drug resistance also. So multiple drugs they are resistant to. So Acetobacter baumannii, a few years ago was a big threat. Maybe it's still a huge problem right now, but it has a lot of drug resistance. Staph aureus has like MRSA, methicillin resistant Staph aureus. So they have developed resistance to over the years, and now it's just difficult to eradicate those bacteria and biofilms if you get infection. Depending on the application of the medical implant, it's still almost same bacteria that we talked, but for urinary catheters, Proteus mirabilis is a big bacteria. Okay, we'll talk maybe soon about why. But E. coli, Pseudomonas, for central venous catheters, Staph aureus, Pseudomonas are responsible. Heart valves, Staph aureus. So, but for urinary, this P. mirabilis is a huge issue, and the reason is urine has lot of high concentration of poorly soluble constituents in them. But if the pH of the urine becomes more alkaline, these high concentration constituents, they start precipitating out. Okay, so now they start forming deposits on the urinary catheter. Okay, and I don't know, in next week we will talk about urinary catheters, but you know, I don't know if you remember, so if they put a urinary catheter, then there is this balloon, they fill it so that the catheter doesn't come out from the bladder, right? But then when it's sitting in the bladder, there is an opening in the catheter through which the urine is coming out. Because of this encrustation happening, or these solutes that are getting deposited there, that hole through which the urine is coming out in that tubing gets blocked. Now urine can start getting retained in the bladder, leading to more infection. And this Proteus mirabilis is responsible for making the pH high. So rise in urinary pH is often associated with bacteria, in particular those that produce urease. This metabolizes to produce ammonium. Rise in pH then precipitates magnesium, ammonium phosphate and calcium phosphate. So that things start encrusting, solidifying, closing that tiny opening, leading to urine retention, leading to more infection now. So I don't know it's true or not. My students told me they did some interview of some hospital nurses, and that particular hospital told them that they change urinary catheter of the patient every 6 hours. I don't know, is it true or not, but they said that they interviewed some nurses and they are changing every 6 hours. I have heard that in US, if somebody gets a hospital-acquired infection, insurance companies are hesitant to pay for those extra costs because they think it's negligence of the hospital. That's why this infection is happening, hospital-acquired infection. Also, the more cases of hospital-acquired infections or HAIs, the ranking of the hospital goes down. So I think to prevent that, maybe they are changing urinary catheter very frequently, but you can imagine it can be very painful for the patient to keep changing urinary catheter so frequently. Okay, so how to get rid of biofilms? Disrupt chemical communication. How can we stop quorum sensing? Bacteria cannot talk with each other. Okay, prevent bacterial attachment. That's the best thing, right? If we can just prevent it from attaching, let's say if there is 1 or 2 bacteria floating, 10 bacteria floating, they are not adhering to your surface, you have antibiotics, they kill the bacteria, you're fine. Once they adhere, they start forming biofilms, now it becomes a little bit difficult. Encourage host cell attachment. So for example, if you have a stent or a medical device, if endothelial cells start growing on it, and now the exposure of that foreign surface is gone, you are reducing the chances of bacteria, because that what do you call it? Artificial surface or implant surface is not visible to bacteria. It's gone. It's covered with the endothelial lining, right? Or antimicrobial materials. And we will talk a little bit today, a lot more next week. We can have antimicrobial surfaces. So some antimicrobial surfaces, passive coatings, making the surface, they are not actively doing anything, they are passive coatings, but they are taking care of bacteria, they are preventing bacteria to stick to the surface, right? So polyethylene glycol or hydrophilic surfaces, super hydrophobic surfaces, that things are just not sticking with water. Water is getting bound very tightly, we talked about it, like for anti-fouling surfaces, right? So it's not sticking to it. Super hydrophobic surface, things are rolling off. I'll show you some video also next week, because that video is my labs video, not YouTube video, so we can probably play it online also. Then there can be active coatings which are actively releasing something to take care of infection, right? They can be actively releasing antibiotics, actively releasing some ions, metal ions. Silver is very common. There are medical devices. Nitric oxide releasing coatings that release nitric oxide gas to kill bacteria. Bacteriophage releasing coatings that is releasing bacteriophage to kill bacteria. Anybody has heard of bacteriophage? Work with bacteriophage? What you said? Yes.
Not actually work with it.
But do you know about what does bacteriophage do?
So it's a virus that eats the bacteria.
So bacteriophage is a virus that can very specifically attach to a bacteria, injects its DNA inside the bacteria, it multiplies inside and makes more bacteriophage, which ultimately bursts the bacteria. So it can kill bacteria. So that's one type of coating. Everything has some challenge, and we'll little bit talk more today and little bit more next week. But here is one way to try to fight infection of medical devices. But remember, sometimes also what happens, if things are active releasing, what if your protein is coming and adhere to the medical device surface, right? Now, maybe it's slowing down the active release of whatever component because you have a layer of protein on the surface now, right? Or if it was a passive coating, but somehow protein got adhered to the surface, now that passive coating bacteria is not even seeing now. So it's there, but protein is on top of it. Now bacteria is seeing protein and it's just easily adhering to that surface. I think little bit I mentioned this in one of the classes. This is just a paper I found, and it was interesting that how sometimes even hydrophilic surfaces or super hydrophilic surfaces can have this embolization problem. So part of this thing broke and can go embolize to another place in the body, right? So here they reported some particles in the heart and brain of the pig model. I think this was a pig study. So PVP coated guide wires, and they saw that this PVP coated catheters placed in swine arteries, 54% of the study animals resulted in foreign material in the brain. So portions of that coating detached and they were found in the, and they even saw that within 15 minutes of soaking that catheters in vitro, they started seeing shredding of that coating. So now for active coatings, you can immobilize something on the surface using chemical reactions. You can embed something inside the polymers. They are in the wall thickness of the polymers and they are slowly releasing. Or the surface is somewhat that's preventing things to stick to it. Or if something is coming to the surface, it's killing it. So there can be different ways to play with the surface. So let's think about controlled release. You know, if you put something immobilized on the surface that's releasing, or you're putting inside the coating, it's releasing something. It's something can be nitric oxide or antibiotic or silver ions. What do you think is the biggest challenge with this control release way of fighting infection? Rate of release is a huge issue because lot of times, let's say you put 100% of the drug, or drug can be silver ions or nitric oxide or antibiotic. Lot of times only 30% is coming out. 20% is getting released. Rest is inside, not getting released. Or it's getting released really fast. You know, you need only 1 unit to come every day, that's enough. But 10 units are coming on day 1, 20 units are coming on day 2. Now it should have lasted 1 month, but you are releasing so fast, unnecessary release, that's it ending in 1 week. And then if you are releasing so high doses, it might be toxic levels of release now. 1 unit would have been okay, but 10 units is very toxic. So this is one of the challenges in this sustaining the release and control release of medical antimicrobials for medical devices, right? Another challenge you can think about is actually, in fact, for anti-fouling surface or hemocompatible surface or for this, any of that, you don't have too much thickness to play with. See, if you're putting a catheter in somebody, you cannot put like this thick coating that's loaded with your drug that you can keep releasing. Your veins are, arteries are certain size. So your catheter has to be certain size. So you have very micron size thicknesses that you have to put on the coatings. And that thickness should be good enough to hold enough drug to keep releasing for whatever number of days to keep preventing that clotting or infection or fouling, whatever you are doing. Okay. So this is what we talked. This is what happens. We want a little bit like that. And I'll talk more about it next week when I talk my group's work, that what we are trying to do to control the release and all that. Control release of antibiotics. So one way is to make biodegradable materials. That way you are releasing everything at least. So if only 30% of the drug was getting released, now if you have a biodegradable coating, coating is going to degrade, coating is going to break, and the drug has to release because it's degrading. But I can also tell you, now the challenge with biodegradable coating is better that degradation rate is not too fast. Because if you are degrading the polymer very fast, the polymer is breaking apart very fast, you are going to release a lot of drug very fast. So how to control the degradation rate while still doing the antimicrobial work, right? So that's one problem. Another thing is, lot of time we cannot do biodegradable coatings, right? Can you give me examples where we can use biodegradable and where we cannot use biodegradable? Yes, we cannot generalize so much, but yes. So sutures is a good place for biodegradable, right? Bone implant, remember I showed you one study where somebody had an infection in the bone implant. They removed the infection and put some biodegradable particles in that. But I know what you were saying. So we can sometimes use, sometimes not use. Now we cannot use biodegradable for vascular catheters because we don't want catheter to start breaking because the tube's role is not to break. Also, you have to remember, if the coating is biodegradable, it's breaking, you are making the surface rougher and rougher now, right? Part of the polymer is breaking, part is still there. Now surface area is increasing, and as soon as you start making the surface rougher, proteins will start adhering to that surface, and now the clotting problem will start, right? So we cannot do it all the time, right? This is off topic, but let me just talk about it because I might forget talking about it later. So one way for vascular catheters, what they do is they do a lock solution in vascular catheters. So if somebody has a catheter That catheter is being used to draw blood or infuse medicine. Let's say they have to do something with it, draw blood or medicine every day or every other day. So what they do is, after they have worked with the catheter, they lock a solution in catheter. It can be a heparin lock solution to prevent clotting of the catheter, or antibiotic lock solution. So they just dissolve antibiotic in buffer and then just put it in the tubing. So now antibiotic lock solution is sitting in the catheter until tomorrow, when they can come and remove that lock solution, work with that catheter, draw blood or whatever, and then put the lock solution back in. So that's one way that's used in hospital also. That biodegradable idea that I was talking about. So there was this study, partial drug release versus complete drug release. They showed that only 77.5% of loaded gentamicin was released from PMMA beads. But for PLGA, you can just release the whole drug. Whereas this study, only 10% of the drug was released. But you make biodegradable particles, you can just read. Okay, drug resistance. So bacteria wants to just survive, right? It wants to grow, survive. Something is coming to kill it. It wants to learn how to still survive and not die and keep growing. The main objective of bacteria is to replicate, survive, spread as rapidly as possible. Microbes adjust to their surrounding and evolve so that they continue to exist. And this is a nice paper actually, if you guys want to read more about it. To survive, genetic modifications might arise, making bacteria immune to medication. Like it's learning how to keep surviving. And this drug is, you know that, sorry, I'm going off topic, that tuberculosis thing I was talking. So there is like multi-drug resistant tuberculosis, right? So bacteria learned how to survive with this drug. So now they have to give a more harmful drug or a higher dose of drug, of different type of drug. And there are only just so many drugs available. So it's just very difficult sometimes for doctor. Also, sometimes what happens, a clinician does not know what infection somebody has. They are approximately giving some antibiotic. And now there can be some, immune bacteria, genetic modifications are happening. It's becoming a little bit different, modified bacteria. Now that's not going to die with that drug. Antibiotic overuse and abuse, inexact diagnosis, improper prescribing, self-medication. In India, we do that a lot. In US, getting a drug, antibiotic or anything is not even possible without going to a clinician. Bad healthcare, poor hygiene, all that can lead to drug-resistant bacteria. So drug-resistant bacteria appeared 1930s and 40s. Penicillin-resistant Staph aureus appeared in London in 1940s. 40 to 60% of Staph aureus are MRSA or methicillin resistant. Vancomycin resistant Staph aureus is there. Hospital infection caused by Pseudomonas and Acetobacter baumannii are sometimes resistant to all the antibiotics. It can be really, really bad, which can ultimately lead to death. So, I mean, more you read about it, it's a little bit scary. Drug-resistant bacteria, infection. What causes drug resistance? Bacteria can change permeability of their membranes. Okay, so bacteria has channels that drug can go inside. It can change. So due to quorum sensing, if they talked and they told bacteria, hey, something is coming to kill you, they can change their permeability so they don't take that drug now. Bacteria can produce beta-lactamase that can break down antibiotic structure. So if this bacteria is telling in biofilm something is coming, this bacteria can start developing, making beta lactamase, so that when that drug comes, it's going to just attack the drug. Chemical modification of drug can happen. Bacteria afflicts pumps. This is cool, right? Antibiotics are actively transported out of the cell. They're just throwing it back out. Now, one example, I'm just going to briefly talk about silver coatings. There are silver urinary catheters, there are silver wound dressings in market. Silver ions disrupt the function of bacterial cell membranes, which is needed for metabolic proteins. Silver can displace other metal ions like zinc and calcium, essential for the survival. Now, with silver, there are good in vitro results, but in vivo or animal results are a little bit controversial. Some papers show it works, some papers show it doesn't work, and silver has been shown to be toxic to human cells. So, but it's in market being used. Okay. You guys think a little bit. If you have to work with bacteria, what are some common ways to work with, let me go to this slide, then I will start talking about it. So when we work with bacteria, you have to be completely sterile, right? So in our lab, we need to have bacteria safety cabinets to work with. Here you guys work with cell culture maybe. So we cannot even get approved to use bacteria if we don't have those biosafety cabinets. I know in labs in past I have seen if people don't have bacteria safety cabinets, they use with that Bunsen burner, heat the that loop to work with bacteria. They so that you can making it sterile and then working with bacteria. So you have to work very, very carefully. There is proper training. You are wearing proper lab coat and taking all the precautions, PPE. Now, who can tell me? So let's say you have a bacteria solution. You are going to work with it. Do you guys know this? Streak plating? Oh, great. Then why do we do it? Why do I have to do this, that? Somebody else. Who will answer that? Huh? Yeah, so why do I have to do this method?
Actually, after this taking the density or the concentration of the bacteria colonies decreases.
To pick the single colony, right? Yes. So you start in this direction, then at this point you go, but you're not keep dipping that loop again and again, right? You just did it once, and then after 24 hours it will look like that. Now if you would have just done this style, you will just see this now. And sometimes if your bacteria is contaminated, like that plate, see, different bacteria make different types of colonies. Big colony, small colony, color of the colony can be different. If you do this method, you can very clearly see, are you seeing two types of colonies? Are you seeing one type of colony? And then you will know, is your culture contaminated or not? And you can just pick the right one bacteria colony to start working with, and you know you're working with the pure Staph aureus or Pseudomonas, right? Okay, now you have to think. So I am making medical devices. I want to test they are antimicrobial or not. What are common ways to test with bacteria? So for example, I give you two catheters, one is antimicrobial, one is not antimicrobial, and now I want you to tell me which one is antimicrobial, which one is not. How can you test and tell me? And I gave you Staph aureus bacteria, and I say, okay, there is a A and a B. tell me which device is antimicrobial, which device is not antimicrobial.
So we can take that loop and on both the catheters, just like we did with the screen of the mobile phone, we can scrape it and then do the similar plating, culture streaking with it. And after the growth comes, since we have a control as S or S, we can see what kind of colonies it forms. So from the antimicrobial one, the silver catheter, the growth would not, one case it should not be at all there, or maybe there is a slight growth. And in the other case, which is the normal catheter, that can have a very dense growth like this.
Okay, so you're saying I have two catheters, I take the loop, I rub the loop on the catheter, both catheters.
Even it is very sterile, we have just opened the package.
Of course. So everything is sterile, of course. Now I'm doing this on this loop, my loop on one catheter, loop on second catheter. Now then what we do after that? So I'll tell you the challenge with your method first, right? So let's say I have this catheter, I took it out from the plastic bag and I leave it here for 5 hours. And now I want to see how much bacteria is on it, right? I'm not sure if there might not be there might be no bacteria even on a control surface because it's just sitting here. So you might have to do 100 studies and then maybe 2 or 3 had a bacteria because while you were opening you were not wearing a glove, or the desk you were putting on, or the lab bench that had little bacteria. So you have to do so many 100 studies on the catheter to see 1 or 2 bacteria getting infected, right? Okay, what else can we do other than that? So now what he's saying is, and you're getting more and more closer to the reality, that we take 2 test tubes of bacteria solution, we put my good catheter and my control catheter in that solution for 5 hours, 10 hours, 20 hours. Then I take the catheters out, right? That's what you're saying. And then you take the loop, scrape it on the wall of the catheter and put it on the agar plate and then see what happens, right? So we are going to talk about this, but that's more complicated. This is more straightforward. Let's talk about this one first. So what zone of inhibition does is, let's say today I have this agar plate, right? That's food for bacteria. I put my Staph aureus solution on it a little bit and completely spread it. Don't do that method. We don't want this method, right? We want very dense population of bacteria on the plate, okay? So that's what I'm doing today. But you cannot see, right? Because you cannot see bacteria with naked eyes. So you are just like putting all the bacteria solution on it on 2 plates. You put piece of your catheter and your control catheter. Let it sit in incubator 37 degrees overnight. Come the following day and see the zone, okay? Why this zone is happening? Who can tell me? So this is all bacteria, okay? All this white stuff that's growing, that's bacteria. This is the zone. This is my catheter. Let's say it's a film, but let's say this is the catheter, right? So that's a bad catheter, control catheter, no antimicrobial. So around it, everything is white, all that is bacteria grown. On my nice catheter that has antimicrobial agent, this area no bacteria grew, right? So there is bacteria here, but it's all dead because I put bacteria on the whole plate yesterday. It's just that bacteria couldn't grow. Here I'm seeing all this white because that bacteria multiplied, and that's why you're seeing. Oh, I hope everybody knows that. This is called colony forming unit. Everybody knows that, right? Okay. Because each one of this started with 1 bacteria, right? Bacteria doubled, and you can now see it because it started with 1 bacteria, so it's 1 colony. Now, We are seeing all this because there are so many colonies here, like just a jungle of colonies. But because of my antimicrobial agent was released from the catheter, that killed all the bacteria in that region. That's why I see zone of inhibition, right? So that's great. But the problem is, it won't work for all types of antimicrobial surfaces. Can you give an example when it will work and when it won't work?
If something is being released from my catheter, it will work.
Yes. So see, if you are releasing silver ions, antibiotics, nitric oxide, you will see this. If your surface is passive coating, PEG or slippery surface, then you are not releasing anything actively, you are not going to see the zone, right? Or if your material is not antimicrobial, it's just preventing bacteria to stick to the surface, it's not killing bacteria, this method won't work, right? Or if you are saying my antimicrobial agent is antimicrobial for up to 1 month, this method won't work, right? Or I was just thinking, what if you keep doing zone of inhibition, right? So you pick up this film, now you put it on the new plate, then you put it on the new plate, and you keep showing that it's still killing, right? So, okay. Now let's go back to the discussion that we were having, right? So, yes, you are almost accurate. So what we can do is, we have catheters, we have test tubes, we put the catheter in it for 20 hours. Now, the following day, you can come and take the catheter out. So first, 12 years ago or whenever I was starting to work on it, somebody had told me what you can do is take the catheter out and roll it on the agar plate. Okay. And then leave the agar plate in incubator. So you are transferring all the bacteria from your catheter to your agar plate, right? And then the following day you can come and see the colonies. Okay. What's the problem with that method? With this rolling method, I can roll it on the agar plate. You guys want your data to look nice. Maybe you will press little less on the control catheters and little or on the nice catheters and little harder on the control catheters, right? So that's why another thing off topic, people always want to do blinded studies. You know, you should, if you want to really do studies well, if one person is making these catheters and doing bacteria study, you can give it to your lab mate to do bacteria agar plate study on it. So there is no bias that I want data to look good on this one versus that one. So yes, so now there can be an error that you are not rolling it properly. Also, from day to day, even if you are super honest, how can you remember how much pressure you applied for today's rolling versus tomorrow's rolling? And is bacteria going to get transferred properly?
The contact angle is a problem.
Yeah, the contact, and then maybe Staph aureus needs more pressure and Pseudomonas needs less pressure. We don't know all that, right? So it's not a very accurate method. So what we do is, can anybody tell me what else can be done? Otherwise, I'll just tell the answer. Yeah, I mean, it's a little bit indirect method, but yes. So one thing you guys didn't say, we will continue this because this is the goal, this is the best study you can do, but you guys didn't guess another one. Can we do SCM? Right? So I put my good catheter, I put my control catheter for 20 hours, then after 20 hours, I can do SCM and look at how much bacteria is on this one, how much bacteria is on this one. Okay, but what's wrong with SCM? There is some weakness or limitation with SCM. people do this, like publications have all this. So I'm not saying these are not good methods, but this is not the most accurate method. And again, I'm not a microbiologist. Microbiology, people can go very deep in a lot of things. But from an engineering perspective, I'm giving an answer. So big problem with SCM is you can be biased, right? See, there is this long catheter of control, this long catheter of your antibiotic. You can look from SCM at multiple spots, and whatever spot looks good to you, you can just put in the paper, hey, look, my nice catheter is amazing and my control catheter has so much clot. You can choose whatever image you want to show, right? So that's one problem with SCM. Okay, there is one more problem with SCM. Who can tell me that? And again, SCM is a good, what you call, additional data that you can provide with the method we are going to talk about. SCM can be a good supporting data to that. But if you just show SCM, lot of times reviewers, scientists don't like it, and I won't also like it unless the study was done blinded. One person did the catheter study, they gave it to their lab mate and said, hey, here are the two surfaces, I won't tell you what is what, do SCM for me. And then let the other person report it, because they are going to look at the whole catheter surface, different spots, and will show a representative image that represents the whole surface. Now that can be an honest way to report SCM. Okay, but there is one more problem with SCM. Who can tell me that? Okay, yes, very good. So we cannot just work in a test tube, because after 24-30 hours, all the food is gone, bacteria is dying. I don't want that. So I want media to be changed so that I have fresh media for bacteria to keep growing. Okay, that's a little complicated, right method, but complicated method. I'll talk about it. Let's go back to doing a simple test, what sometimes people do. So let's say I'm saying my material is antimicrobial for 1 month. So easy method what we can do is, not that accurate, but still okay. You do a 24-hour bacteria study like we talked, but your other catheter pieces, you put it in 37 degrees Celsius, pH 7.4 for 1 month. He thought about that, but he didn't say it. You keep it for 1 month and then repeat a 24-hour study again. So basically you are saying you were mimicking the release in buffer 7.4, 37 degrees for 1 month, and see, even after a month you are still releasing drug to keep it antimicrobial. You can do that, but see, in reality it's going to be sitting in blood. Now it's sitting in buffer. It's not the most accurate way. So the accurate way is what you guys are saying, and we work with a bioreactor. Okay, so there are two main types of bioreactors we work with. One, we call it CDC bioreactor, and we worked with CDC also actually for a few years. The person who worked on this bioreactor a lot, Dr. Rodney Donlan, is my good friend. He just retired last year. He worked on this a lot. So here the idea is what you guys said. That's the green, that green one is the bioreactor. You put your samples in it. You put your media, bacteria media in it. You let it sit for a few hours, and then you start the bioreactor, a stir bar and a pump, fresh media. So fresh media is going in the bioreactor, waste is coming out of the bioreactor, and you can keep running it for weeks. Okay, and after whatever time period, you can take the samples out, homogenize them, plate them, and you can do it. What can be a challenge with this method? Can anybody guess? I mean, this is a good method. I'm not saying we need a different method, but it's a challenging method.
So the nutrient supply and the waste removal rates could be a problem. We
So
might not be removing enough waste at the rate with which we are
that we
producing
have
nutrients.
practiced now, we know at what rate to flow the stuff, but we have to keep changing this media because it's going to keep getting empty every 2-3 days, even with the big containers. Few days we have to keep changing it, few days we have to keep changing that. Other problem we see is sometimes some bacteria that are very opportunist and they grow very fast. We have seen bacteria sometimes start growing here and bacteria start growing here and it starts going out of control, bacteria growing. And since all the bacteria studies need to be done in a very sterile way, sometimes if you are running it, students are not careful. Even if they are careful, every 3 days you are putting a new container here. You can introduce infection to this system and now you have multiple bacteria start growing. You started with Staph aureus and now you have like 3 more bacteria growing in that system. So that's a challenge so we have done highest amount is 6-week study with this. But I know students had challenges sometimes. After 5 weeks, there is a contamination, so the whole experiment is gone. So you have to start it again. And some bacteria can be very stinky, so the lab starts stinking really badly when you're working with those bacteria. So, I mean, we have a separate room for bacteria work, but still it can be difficult for students to work. Okay. So that's this bioreactor. This is an example showing live dead staining of bacteria. The top one is a control film. The bottom one is our nitric oxide film. We will talk about it next week. But you see lot of green, lot of red, live versus dead bacteria. Okay. Last slide to end today's talk. In another method of bioreactor is drip flow bioreactor. Okay, so CDC bioreactor, you have catheter pieces completely submerged in liquid. So almost, we have liquid up to here. See, this is that the what do you call it? Waste, right? See, the good media is coming from top, good food. This is waste is going down. So we have liquid up to here. Our catheter pieces are bound to these. But this method, you have catheter pieces or whatever surface in this, and you have the liquid coming from top and just sliding down, and it's coming to waste. That liquid drop is not continuous. It's like drop by drop, and you are not filling this whole container with liquid. Can you tell me what's a good, for what type of medical device this is a better bioreactor compared to this bioreactor? Yes. Okay, that's good. So cannula, we will go CDC because, yes, right? Because see, cannula is going to sit in the blood like liquid for a long period of time, right? CDC is like sitting in media all the time. But a wound healing patch is more semi-wet. It's not like drenched in liquid. This is like a semi-wet condition, right? There is liquid, it's like little bit, it's not dry, but it's not sitting in liquid all the time. Okay, there is one more good example for this type of I almost said it. Okay, there is one more medical device we can use this method. And you can answer that. We have talked about it a little bit. Sutures is good. That's like more like wound healing, but yes, you're right. Like little semi-wet type application, sure. But there is one good one. Urinary catheters. Right? Oh, you guys thought about it? But you didn't say, see? So urinary catheters, it's not like the catheter is like always flowing urine through it. It's like a moist environment, sometimes liquid, sometimes not liquid. So we can test that with this method. So there is like a air liquid interface, little period of little dryness, but not dry, but wet, but not drenched in liquid. Right? So we keep flowing that liquid, the media, there is a pump. It's the same setup. It's just we are changing that green CDC reactor with this drip flow reactor. And then after whatever time, you take the pieces, you homogenize it, and you look at the colonies and everything. Endotracheal tubes can be, yeah, see, I didn't think about it, but you are right. That might be a little bit like that type of application. Yeah. Okay, there is one more application that dip flow can be a good method to do it. If you are saying your surface is anti-fouling or slippery surface or super hydrophobic surface, because if we test our very super hydrophobic surface, or depending on the application, right? If my super hydrophobic surface is going to be used for a vascular catheter, I have to use this method because it's going to sit in liquid. But if I have just made a material that is, I'm claiming, I'm not talking about what medical device I can use it for. I'm just making a journal material and I'm saying, hey, you know what? It's anti-fouling, it's super hydrophilic, it's super hydrophobic. Maybe this method can be better because you have a drop of bacteria or whatever coming and rolling off, right? But if you have a particular application in mind, then you have to decide, is it going to be soaked in liquid or is it going to be a semi-wet condition? Okay, guys. Thank you so much. Next week, we will talk nitric oxide releasing materials and some strategies to make hemocompatible anti-fouling surfaces, grant writing, little bit commercialization, technology transfer, ethics, some tips for graduate students, postdocs, some of these things. Academia versus industry, these will be the topics for next week. But thank you, have a good weekend.